So first off, I think we have, let's go in the order I wanted to put it in. Let's download everything here and download everything here, open that one, and we've got the X-ray. Okay, so first off, we've got a chest X-ray. Look at the chest X-ray. I haven't seen anything that's grossly abnormal. Everything looks okay. No evidence of any continuous diaphragm sign. Slightly rotated, because if you kind of draw where the clavicle is there, you've got your spinous process that is sitting there. And that really should be in the middle because the clavicle is the most anterior aspect of your body, the spinous process is the most posterior aspect of the body. So that for them to get out of line with one another happens sooner than something that's right up next to each other. And that's why you don't use the clavicle with the sternum, because if you have something so close to each other, for them to go out of line with one another takes quite a while, right? Look at that. Whereas you've got something quite far from each other, they kind of get out of line quite quickly. So it's a really good way to try and figure out whether someone has got, their rotated film. But on this one, we don't really see anything grossly abnormal. Everything looks okay. I'm not particularly worried about this. But the patients come in with abdominal pain, and yeah, they've come in and got a CT scan. So let's go from the very, very top. From the very, very top here. Okay, so we can see a little bit of gunk within that lung area there. So let's have a look and see what's going on. Yeah, it's a little bit like the other patient we had earlier. Looks like there's a bit of spherical thickening of the bronchioles over there, maybe a bit of mucus plugging, a bit of atelectasis. So there's clearly some sort of maybe infectious process, like a bit of consolidative changes, a bit of gunk all sitting there as well. Now let's go back to the abdominal windows. Let's bring it back to the middle of the screen and go back to zoom and scroll. And let's go from the very, very top. And as you scroll from the very, very top, let's just do one run through just to see what's going on. So sometimes from the musculature of a patient, you can see that they're probably not that old, because if you've got kind of a slightly older patient, they don't have, big muscular glutes and, abs and all this stuff. So the patient's quite young, clearly. They've got big paraspinal muscle, probably doing a lot of deadlifts and that kind of thing. It's quite a young patient. And as you scroll through, you may have spotted that there is this little dot here. Can you see that? Little dot there. And then you got that dot is very, very black. Very, very black is going to be here as well. Very black here, very black here. We know the lungs can be black because they're full of air. Everything outside of the body is going to be air. So anything that's kind of black on this picture is going to be air. So the lungs kind of finish there. And then you've got these dots. Can you see that? And another bit of low density there. So it looks like air. And if we go to the lung windows, you can see that, yeah, there is definitely some air that is sitting within the upper abdomen. So straight away, we should be thinking to ourselves that this patient has got what is called pneumoperitoneum. Something has burst, right? Something's burst, right? So first of all, what phase of imaging? We've got the artery versus the portovenous system. The portovenous system looks slightly brighter, so this is a portovenous image. Scrolling through, the liver looks okay. The gallbladder looks all right, actually, doesn't it? And then we look at the kidneys, which is sitting here and here. Some of you may have spotted a simple cyst there, simple cyst, but actually there's not really much going on there at all. Everything looks pretty good. Intrahepatic duct dilatation, no, maybe you can say a little bit. Can you see there, tiny bit there, but not enough to really think that this is going to be the underlying cause of the patient's problem. Spleen looks okay. So now we've got to do a little bit of work just to make sure that it's not the large bowel that has perforated. So go from the bottom, quite literally, go along like so, and we can see the bowel going this way. Follow my mouse. We're going this way, scrolling around. We're going this way, this way, this way, this way, this way, this way. And then we can see that we're coming up to the descending colon, and you're coming up to the splenic flexure. And as you come to the splenic flexure, you can see there's a little bit of fluid sitting there, coming across to the transverse colon, which is here. We're going right across the front. Oh, we're looking like we're going behind some like slightly dilated bowel. Can you see that slightly dilated small bowel? And we're creeping around the back and then going down the side, and we're coming up to the cecal pole. And now we've got I don't know if anyone can see that, but I do wonder whether the appendix is just sitting somewhere within that region there. But anyway, the large bowel looks okay. Doesn't look like there's any problems there, but you've still got a lot of air sitting within the upper abdomen. So even if you didn't see anything else, what you have to notice is that, well, you do have, what you notice is that you've got lots of air within the upper abdomen, don't you? So the most likely cause of air from the upper abdomen is going to be a perforated duodenum, or it's going to be a perforated gastric ulcer. And so what we need to do is try and have a look and see whether we can find it. So if we come up to the esophagus, gastroesophageal junction, going right around like so, we're coming up to what looks like the pyloric, coming up to this region over here, and we're coming up to the duodenum. We haven't spotted anything grossly abnormal or obvious at this present time. But what we might need to do is go to the lung windows, and just to be 100% sure that we haven't seen anything anywhere. Why is it not working? So there, and lung. So let's see if we can find the stomach, going along like so, going right, and there you go. I don't know if anyone can see that. So I can see that now. I'm going to go back to, so if you keep it, can you see that little tiny trickle of air sitting within that region over there? I do wonder whether that could be the thing to be worried about. So let's go back to abdomen. And you can see there's a bit of outpouching, a little bit of air that trickles out that way, and you've got a little bit more air sitting over there. So I reckon that is going to be the source of it. That's going to be the source of it. So it's going to be around the pyloric region, a little outpouching there, coming out that way, that way, that way. And then you've got a few more lockets of air sitting within the upper abdomen. So this is most likely going to be a perforated duodenal ulcer. Right. So, and then obviously we've kind of gone through everything else just to make sure that nothing else is going on at all. Yeah, everything else looks okay. I don't think we're worried about anything else. So I think we might be running out of time. Let me just make sure. Yeah, so I think that was the last one. So I think that is the last one. Oh yeah, and then for those of you that do want to go back and you are worried as to where if you can't see where it was, there it is pointed out nicely for you if you do want to relay and have a look at it later. So anyway, we've had a few good cases. We've gone through a bit of liver stuff, a bit of bowel stuff, and hopefully quite common findings. And I think if you are to go back from the beginning of us doing this series to now, you'll pick up little nuggets of information that are hopefully building on a bigger set of knowledge that will help you later. I hope that's been useful for everyone. I really do appreciate those of you that did turn up, and I think there was a slight mistake with the timing at some point, so apologies for those of you that weren't able to see it. Do please share it to people, once it's online, to everyone, man, to your family, friends, anyone that may be interested, even someone that you don't like very much, go send it to them. Okay, cool. So, Sada, I'm going to hand it over to you. Thank you, everyone, and I'll see you soon.